Yeah. Weights? You're gonna use some weights?
Yeah.
No weights? Like adding weights to your survey to make it nationally
Oh,
representative?
no, that's not so.
I'll end this session when it's done, so it's not recording, and then when it's.
I'm so sure that.
Oh, nice.
It's a fun site. You'll hear me explain.
Oh, no, I might.
And she's going to use surveys. So I was like, oh, I teach the PRO class. I know you. You teach the PRO class? I need a PRO class. Why can't we just like do it with you?
I am.
No. Yeah, that's when we need it, but next year. We teach our grad classes every other year. Are you gonna do it next? No. I mean 2024. Are you gonna teach it 2024?
2024, I was teaching part of my
Okay, switch on. Come on, switch on.
I don't think I can.
What are these?
I wish I could teach
PRO, I should report it out.
No, I teach one graduate, I teach a graduate class in my spring, but it's a fish report out of one year. But I will admit, it's based on
Okay.
I'll leave you.
I'm glad that you love it.
It is the one, my most favorite thing I do.
Do you know Teresa Shireman at Brown University?
I might.
She moved.
I know my.
One of my colleagues told me.
Good, you know, we
They
have
have one year one.
another one coming out.
I need to introduce
Have a how-to for pharmacy students.
She's amazing. I'm gonna do it.
First
And to my colleague.
part is just general stuff, how to write a research question, how to find a research mentor.
I got it.
It's for an elective kind of thing.
I'm gonna ask everyone to take their seats. It's 2:00.
Yeah,
We're gonna start our short orals,
yeah.
and we'll have one more set of short orals tomorrow. So if you are in the Wednesday session, please bring your USB drive after this session so you can load your slides for tomorrow. And without further ado, we're going to get started. And again, as yesterday's procedure, we'll give the presenters a 10-minute, and a 5-minute, and a 2-minute warning for their session. The Q&A is the most enjoyable part. I think that interaction with the presenter. I failed to tell you yesterday, on the ISPW 2022 site, you can find the oral abstracts, and specific to Chicago, starting at the 200 with the 4 that we saw yesterday, today's, and then it'll continue for tomorrow if you wanted to see the full abstract. Without further ado, I'm going to invite him up to the podium.
Hi everyone, my name is Amna. I am a pharmacist by training, and I'm currently a PhD candidate at the University of Michigan. And it seems like most of you already know who my advisor is, who's also here at ISPW, Dr. Karen Ferris. Today I'm going to be presenting on predicting confidence to manage symptoms and to seek medical care in patients that are taking oral oncolytic therapy. So our aim was to assess the relationship between symptom severity in patients taking oral oncolytics and their confidence to, 1, manage their symptoms, and 2, know when to seek medical care for their symptoms. This is important because there has been a dramatic increase in the development and use of orally formulated chemotherapy, also known as oral oncolytics. And so these drugs have been great for patients. They're convenient because they can be administered at home, but these drugs still have problematic side effects that need some clinician oversight. So patients at home need to be able to recognize their side effects that arise and need to be able to know how to manage them. So the picture here shows some symptom management techniques. For example, you can apply creams or ointments for rashes as appropriate, or take over-the-counter pain medications or prescribe medications for nausea. So sometimes medical management is unavoidable for these side effects, but many times they can be managed by patients at home, which can avoid costly visits to the emergency department, for example. So we're finding that patients with severe side effects are more likely to be less adherent to their oral oncolytic regimen, which can then ultimately lead to potential cancer progression. So what we would like to do is help increase patient confidence to manage their side effects from their oral oncolytics, which can then increase their symptom self-management capabilities so that they can ultimately avoid the decrease in quality of life and increase in financial toxicity that comes from unnecessary use of healthcare services. So for this project, we conducted a secondary analysis of 653 patients, patient-reported outcome measures, also known as PROM. So a 19-item PROM that asked about symptom severity, oral oncolytic adherence, and confidence was completed by adult patients that were newly starting an oral oncolytic medication between July 2016 and December 2018 across multiple sites in Michigan. And we just used simple linear regression for the analysis. So here you can see the dependent variables that measure confidence. We had 2 questions that we asked patients. You can see them on the screen. So patients are ranking their confidence to manage their symptom and to know when to seek medical care from 0 to 10, 0 being not confident to 10 being confident. And these questions were adapted from the patient activation measure, or PAM, that Dr. Ferris has used in her previous work. So, and here you can see the independent variables, which were just symptom severity. And so there's a portion taken from the PROM for the symptom severity. There are 4 symptoms listed there, but there's 14 in total. And this was a modified Edmonton Symptom Assessment Survey, so ESAS. And patients ranked there, for example, pain on a scale of 0 to 10, 0 being they were having no pain, to 10, they were having the worst possible pain imaginable. So each of these independent variables, since I was doing simple linear regression, was entered separately with each of the dependent variables that I described on the previous slide. Here's just a table with some of the descriptive statistics for the variables of interest. So the dependent variables are highlighted in yellow at the top. You can see that on average, patients rated their confidence pretty highly. The remaining rows beneath the confidence dependent variables are the symptom severity rankings, so the mean, median, and standard deviation. The 3 symptoms that are highlighted in orange were the symptoms that on average had the highest scores. So tiredness, then drowsiness, then pain. Here is the table of results. So here are my predictors of confidence to manage symptoms. The symptoms are listed in the first column, followed by the regression coefficient, and then the R squared. So the p-value for all of these symptoms, because they were entered separately in the regressions, is less than 0.05. And you can see that depression, anxiety, and nausea have the most negative impact on confidence to manage symptoms. Here's a table of the predictors of confidence to know when to seek medical care. So here we have quite a few less symptoms. We have 4 symptoms that showed up with mouth sores having the greatest negative impact on confidence to know when to seek medical care. And all these symptoms were again significant below 0.05 p-value. So from these results, you can see that depression, anxiety, and pain are negatively related to both confidence to manage symptoms and to know when to seek care. But more symptoms were associated with confidence to manage symptoms versus confidence to know when to seek care. So this indicates that potentially patients with depression and anxiety could require additional supports during their treatment with oral oncolytics to know to help manage their symptoms from them. And then in future research, we would like to explore these relationships over time, as well as different ways to enhance confidence to provide optimal support for patients taking oral oncolytics and to build more complicated models. So I submitted this back in 2020, right before the pandemic, and we resubmitted the same thing, but Dr. Ferris's statistician Vince was kind enough to carve out these 653 patients for me to begin to learn coding and stats. So it's funny seeing this now as going into my third year and how much I've progressed over the years. And so like looking at this data, I'm like, oh, I would like to do this and that. But this is what I'm presenting for now. But these results actually piqued my interest and confidence in general. And so this is the topic that I'm pursuing further for my dissertation. And again, it'll be in patients that are taking oral oncolytics and we'll be using PROs. So yeah, that's it for now. Thank you. Yes.
Your confidence measures, one of them had a median of 10. So, perfect, right? But standard deviation of 2.7 and a mean of 8.5. So there must have been a relatively small group, but they were really low on the confidence. Do you remember about, I can't do the math in my head, was it 10%, 20%?
So good question. So actually the primary analysis took that into consideration and that's what Dr. Harris did. But I can't remember the portion, but there was a significant difference between people who had high confidence and people who had low confidence. So actually wanting to explore this further for my dissertation, I want to like stratify those groups and perform analyses.
Yeah, because it's like, oh, this is great. Almost all of our patients have high confidence, but it's the relatively few that are really struggling.
Right, and that's who we want
Got a
to
few there. It's
focus on.
interesting.
Yeah.
Thank you.
It's about a quarter of people who.
Isn't that interesting? So, if my plane only crashes a quarter of a time, that's not good. As a practitioner, if a quarter of my patients are really struggling, that's not good, right? Good, very interesting.
Hey, Amna, well done. Congratulations on your presentation. So question, once you have these results, what would be the next step? And how would they inform future actions in clinical practice that you would like to target these patients with?
Yeah, so great question, because we always want to see what it'll do in clinical practice. So kind of related to the question earlier, we want to incorporate confidence measure in clinical practice so that clinicians can identify patients who have lower confidence and then focus their support for those patients. And so we would like to develop interventions that are aimed towards patients that have lower confidence, since clearly people with higher confidence are doing well anyway. That way you can allocate resources appropriately.
Thank you.
Would you just tell them in 3 sentences what your dissertation is going to focus on? Because I think it also builds on this.
Yeah, so I am doing a mixed method study looking at patients who are taking oral oncolytics, and I would like to look at if there's confidence to manage their symptoms and their confidence to not seek care will influence their healthcare utilization. So I will be observing them over 6 months and then administering several PROs and with symptom severity and confidence being one of some of the measures. And then I would like to interview for the qualitative portion patients with different levels of confidence and healthcare resource utilization to see what themes emerge. And then I would also like to interview the clinicians that are part of the care to see like symptom management from the clinician's perspective.
Can you go back to your last slide, the summary? Yeah. I just want to follow up on this so I make sure I understand it, that depression, anxiety, and pain were negatively related to both confidence to manage symptoms and to know when to seek care. If I'm understanding that right, that means that somebody that is experiencing, let's say, pain is in turn not as likely or to know to seek care?
Correct.
Okay, okay, which seems somewhat counterintuitive.
Right.
I mean, I'm thinking to myself, if I'm experiencing pain, yeah, I better go do something about it.
Yeah, so I'm glad you brought that up because we talked about this. So our theory is that patients who have medications already for certain symptoms, it might introduce more of a gray area because their clinicians tell them that, hey, you're gonna have pain, you're gonna have mouth sores. And so we're sending you home with these medications. And so they know that like, oh, okay, I have these medications, I'll take them, but they don't know when exactly like they can no longer, just take self-medicate at home and when they need to call and go in.
Okay.
So I think that's what's kind of, okay.
Yeah, thank you.
So
That's just a tiny follow-up to see if I understood it correctly, because so depression is related to if you seek help for depression, or is depression related to if you seek help for anything, or if you know about anything type of symptom?
So depression, they rank their severity of depression, and then we wanted to see how or if it was related to their confidence to seek care or their confidence
Confidence in seek care
know when to
for,
seek care.
for depression,
for any symptom.
for any symptom. Okay,
Correct,
so,
yeah.
so what we can see is that if you're depressed and you have a lot of pain, you don't have the energy to actually do the cognitive process of thinking, now this is the time when I need to go.
Yeah, potentially.
doctor.
So that's something I would like to explore, like in the qualitative portion of my dissertation, to see what's going on.
And is this something that you feel is unique to this particular population of oncology patients, let's say relative to other, patients with other conditions? I mean, because I guess I'm thinking of this from my perspective of obviously not having cancer, and when I experience pain, it's like, yeah, I guess I better go do something about that.
Yeah, I mean, that's a great question.
yeah.
I think that since cancer patients are already expecting to feel pain,
Right.
maybe they are, feeling differently, but that would be a good thing to look into
Yeah.
for, like chronic conditions and how that affects people, so.
Going back to the comment about if I'm depressed, then I'm not energized to seek care, but I'm suffering and I don't know how to seek care for maybe some other reason. That could lead me to delve into depression. So you've got your dissertation is going to be quite revealing.
Yeah, the workshop today is great because I want to see mediating and moderating effects in my.
I'll pay you later.
Now, I've also seen this with oncology patients not realizing the side effects of their medications, like cardiovascular issues. They don't think of talking to their oncologist or anyone else, and they're finding out, oh, I don't have any heart issues. Now what do I do? Even though they feel like they do. So I could see this even expanding for some of those other side effects.
Yeah, definitely. So the 14 that we focus on are just the ones that are most commonly experienced by any cancer patient, since we're not focusing on a specific cancer site. So that's why we focus on these, but that's a great point. Yeah, because there are certain classes that have,
Well, and I think the other thing too is I think from working with cancer patients, they expect to get more side effects with IV, not with oral. So this is really great
Yes.
to look at this particular point.
and that's not necessarily true, correct?
Right,
Yes,
right,
that's-
exactly.
All right, well, thank you.
Thank you. Oh, did I put them in the wrong order?
Oh, somebody's going.
I messed that up.
Oh, it's okay. I got it.
It's gonna take away from your time though, Marcia.
Trying to test my technology
Clock
skills
is
here.
Clock is ticking.
Let's go click, 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 click.
Patient
How
tick
come I
tock.
can't get the mouse? I'm like using my finger.
I'm
No, it's
sorry.
okay.
My mistake.
All right. Okay, great. Thank you, Beth. I failed the technology test. Can everybody hear me okay? Okay, thanks. Well, it's a pleasure to be here today, in person. This is my first conference in, I think, 3 years. So it's really been great to interact and have all these vibrant discussions with everybody. So today what I'm going to share with everyone, this is part of a pretty big survey that I've worked on with colleagues, and I'm going to specifically talk to you about the pharmacist piece. So pharmacist views of their roles, and I'm going to share with you results from a national survey. I do want to start off by acknowledging, I'm trying to find the page now. Gosh, I have interacted with the computer before. I do want to acknowledge my colleagues and collaborators, Dr. Anandi Law from Western University in California. We've worked a long time as research collaborators, pretty much since graduate school. And her fellow, Dr. Yuni Kim, she's a fellow doing a fellowship in health outcomes research, has been really instrumental in this project. So again, I want to acknowledge all the hard work that we've done as a team. So as we think about, in our profession, we're striving as pharmacists, we're teaching our students as a profession, we want to be practicing at the top of our license. And there's been a lot of changes to pharmacists' roles over the years, and particularly as we've seen, COVID-19 and the global pandemic and things like that. So it's really important to kind of take a pulse and check and see what pharmacists' perceptions
of their roles are on the patient healthcare team. So we developed, we used a cross-sectional survey design. We had an online Qualtrics panel, which was a nationally representative sample of pharmacists. And we wound up with our final end being 205. And we administered this survey in November of 2021. And I will say, as a side note, it costs quite a bit of money to actually, so I'll explain a little bit later, we surveyed patients separately, physicians and pharmacists, and it took the most to incentivize the pharmacists as part of this Qualtrics panel to complete the survey. And I think part of that is because they're so busy with all of their different roles in the healthcare team. So it's about, I think, $300. Anyway, side note, just about the difficulty. So we developed the survey that we used in this particular study, and we wanted to look at different aspects of the medication use process. So you see, I've got the step, these are the actual steps that we developed items for each of these specific steps: prescribing, transcribing, dispensing, administration, and monitoring. But then we wanted to look at other things that pharmacists are doing in terms of direct patient care services, and interprofessional collaboration. And then obviously we collected different respondent characteristics to describe our pharmacist sample. Now, what I'm going to present today are the quantitative, data from the survey. We've got a lot of qualitative data that we'll save for another time. So, we just ran certain frequencies and things like that in SPSS. So let's kind of get, before we get to some of the key results, this is just an example of, I thought it might be good to see just an example of one of the survey items. So remember, thinking back to the steps in the medication use process. So this is just one of the examples of a question in the pharmacist survey. So which of the following could best help monitor patients regarding their medications? And we allow them to select up to 3 choices. So we spent a lot of time debating, how many they should select. Should it be all? We ended on 3. So you see those different answer choices there are different healthcare professionals, technology, health insurance, things with the health insurance plan and or the PBM, and then we allow a free form response. Now, the interesting part and where we have a lot of this rich qualitative data is we wanted them for each question, each of the 15 questions, for the pharmacist to then explain why did you choose? So say the pharmacist is answering it and they're saying, hey, we think it's us pharmacists, then it's maybe physicians, then it's technology. Why are they choosing that? All right, so let's hop into some of the key study results. Thanks, Beth. Okay, so again, this sample we're able to select the representative sample of US pharmacists in terms of age, gender, and ethnicity. So just to hit some of the highlights of the description of the pharmacist sample, about half of them have been in practice for 20 years or more. The majority you can see there were practicing in pharmacy chain stores or in the hospital setting. And the majority cared for, a large group of patients in their practice. And that's exactly how we phrased it. So not a certain number a day, but kind of overall, if you think about the practice of the patients that you're taking care of. So again, a fairly sizable population of patients that they're taking care of. So some other interesting results. So, and maybe some of these are maybe not surprising, but you can see there about half of pharmacists so these were Likert type questions. So agreed or strongly agreed that prescriptions are written error-free. Honestly, I was a little surprised with that number, but I thought it would be lower than that. But anyway, that patients use their medications as directed most of the time and are monitored and followed up as needed. Okay, so again, this is a sample of these 205 pharmacists. These are their perceptions, based on their caring for patients. So then one of the other key questions that we asked, who do patients first connect with when they've got some type of health-related problem? And pharmacists believe that patients reach out to pharmacists first. You can see roughly 40%, and can best help patients with counseling and taking their medications as directed, as well as monitoring. So these things kind of make sense, right? They're things that fall into, what we think pharmacists normally do: counseling, counseling patients on how to take medications as directed, and doing some of that medication monitoring. Now, another question that I wanted to highlight, we asked, how can better decisions be made about medication therapy for patients? And these were the top 3 that pharmacists mentioned. So physician-pharmacist collaboration, less insurance restrictions. So no kidding, here in the US, we know that insurance is a huge barrier for patients as well as pharmacists and other healthcare professionals, as well as having more time to spend with patients. So that's what the pharmacist in this sample identified as things that can help them make better medication therapy management decisions. And then looking at, okay, what in the pharmacist's eyes, which of the following would best help reduce medication dispensing errors? And these were the top 3. I didn't list all the categories, but these were the top 3 that pharmacists identified. So staffing, working conditions, and the environment in that particular pharmacy, and time comes up again. So some of these are not surprising findings. Now, if we look at collaboration, we asked a question and had these responses here on the right in the legend. What services are you comfortable collaborating on? So I'm just going to highlight some of the main ones here. So if you see on the right side of the pie chart, things that pharmacists are in this sample that they're really comfortable with things like monitoring. So again, looking at that monitoring area, so monitoring effectiveness and safety of medication, monitoring medication adherence. And then we see moving over, I guess, counterclockwise, medication counseling is another big one. And then MTM and vaccination, okay? Which is, I think, as we think about vaccination, obviously a lot of focus now on the COVID-19 vaccine, when we did the survey, as well as other vaccinations that we know that pharmacists can do. All right. And then the last thing I think I'll highlight here is, if we asked pharmacists, what do you think are some of the big challenges to pharmacist and physician collaboration? And some of these, some of them are not surprising. So time it takes to collaborate, lack of an appropriate setup within that pharmacy to actually do the collaboration. And then in the blue, 25.1% challenges to interprofessional communication, thinking about roles and expectations of the different healthcare providers. So I'll wrap up here and talk about some of the study implications. And I think I'll talk, thanks Beth, I think I'll go to the bottom bullet and just share with you that this study is part of a larger study where we use the same rubric, the medication use process and all of those things, but we studied physician perceptions. I talked to you about the pharmacist perceptions. We also studied patient perceptions. So again, thinking, okay, this is what pharmacists think about their roles and what they're doing on the healthcare team. We need these other 2 pieces, right? So if we think about the framework for this study, it really is role theory. So thinking about, okay, everyone has roles, patients have roles, physicians have roles, pharmacists have roles. Everyone has a set of expectations about who's doing what in their particular roles. For relationships and outcomes to be optimized, those roles have to be aligned. So those are the other kind of pieces that are going to round out this study and help us kind of understand a little bit more about, what these other important partners in this healthcare provider patient relationship think. So I went to the bottom, but I'll go back up to the top. If we think about some of the results that I shared with you, and again, I couldn't share everything, but just what we're seeing now, pharmacists, they do perceive that their roles, are aligning with some of the expanded role opportunities that we see in the healthcare system. And this is partly shaded by what I know about the physician data. If we truly want to expand pharmacist roles on the patient healthcare team, again, that physician is a key player. We've got to continue to work on creating that awareness, that acceptance of the pharmacist's role in the healthcare team, that the physician can trust the pharmacist. You know, we hear these things about, you know, turf wars, scope creep, and things like that, that we're still working hard as a profession to overcome. And, you know, I mentioned already, patient perceptions, that is a critical piece, I think, and we would probably all agree with that. I really believe if we could get patients more on board, that their voice is extremely powerful. That's just my opinion, you know, in driving role acceptance of what pharmacists can do. And the last thing I'll say, I'm getting the 3-minute sign, you know, is we're thinking about, this is my biggest fear was, how am I gonna get this in 5 minutes? And it's probably beyond that, but thinking about, okay, so we have practice implications from this work. Obviously, there are research implications and further things that we're doing and others are doing, some of you in this room perhaps, but also thinking about the education of our students. So, you know, again, we hear the constant emphasis on interprofessional education. We've got to, you know, continue down that path to make physicians aware of what pharmacists can do. So I guess with that, I'll stop and take questions. I have 2 minutes.
Okay, I gotta ask,
Okay, sure.
you know the patient data, are the patients beginning to look at pharmacies and pharmacists as a place to go to help solve bigger problems that are produced by the healthcare system and their physicians? Are you seeing that?
Yeah, what do you mean by bigger problems?
Everything from cost of drugs, or going to the pharmacist and say, you know, you're accessible, you can take care of my problem. I don't want to set up a clinic appointment 3 weeks from now. I want you to help me now.
I don't think we've seen, so it's an excellent question. I don't think we've seen it like swing all the way there.
No. But are you
We're
still
seeing
moving
some
it?
of that, and I will say, so the physician piece, we presented at APHA, the patient piece is gonna be presented at AACP teaser. So we are seeing some of that. And we've got a boatload of qualitative data as well. So we're looking at different themes, and we're seeing things like burnout and all kinds of things. But I think Betty.
No, Dan had his.
Oh, sorry, go ahead.
Interesting study. Is there like a typology for pharmacy practice in the US? Like so a lot of my PhD work is around that, and it defined which activities are traditional and which are more novel. Does that exist, like say 70 activities for a typical pharmacist?
Yeah, I think so. I think to a degree, I think that Beth is back there going like this. So I think like if we think about the patient care process and those steps, like all of those. So I think that gives us a framework. But, you know, pharmacists are also, you know, getting involved in providing different kinds of healthcare services. So things like medication therapy management, vaccinations, you know, they can.
COVID testing.
Thank you. COVID testing, Lourdes, my helper there. Right, so COVID testing. So there are a lot of things that pharmacists can do that aren't necessarily like written down on paper today, right? That we can dream big. Pharmacists are trained as medication therapy experts, right? So they can do lots of different services, adjust medications, and different things like that. So if I'm answering your question correctly, there is a framework, but there's kind of room to move out of that a little bit.
Yeah, if it was resurveyed over time, say every 5 years, you get a good picture as to how pharmacy practice is changing, I guess.
Right, and this original study was done, I would say, and it was very different, but it kind of had that same essence, probably like 20 years ago. Yeah, sorry, I don't know who I'm going to next. Betty?
Well, I love your work. I always love your work. So I want to start out by just saying that. But the second thing I wanted to say is I'm kind of surprised that a larger percentage of pharmacists don't say that they're the most important, you know? And so then I am really curious, what were the highest percentages? Were the 39% and the 33%, or were those the highest percentages, or did they put physicians above themselves? Or
no, in most of the results, they did put themselves first. Yeah, in most they did, but it fell into some of those things related to dispensing, monitoring. If we think about the medication use process, dispensing, monitoring, things like that. I was kind of surprised about some of the things like around with the collaboration piece specifically, that the numbers were a little bit lower. and even the vaccination and the NTM. And even some of those things around collaboration, thinking about adjusting medication therapy and things like that as we think about collaborative practice agreements. So some of it was a little bit, some of it made sense and some was surprising. But we do have a small sample.
Do you think that Betty's question relates to the select up to 3? Because then it's not ranking 1, 2, and 3, it's of the 3.
Yeah,
And so I think that's where those numbers like 30%.
It could,
And that's where you have to, think about it.
I'll be honest with you, we struggled so much about how to word, like just writing the questions and how to do the response options. As academics know, we spent a lot of time thinking about that. So that maybe it is an artifact of that. I didn't think of that. Thank you, everyone. I'm happy to talk with anyone more. I've got so much qualitative data too, so I'm trying to figure out how to get to the next.
I can take that.
Oh, there it is. Okay. No, it's not good.
I got it.
Oh,
And that's not it.
thank you.
So I'm so pleased to be here. I'm so pleased that you're here, and whoever is anyplace else, I'm glad you're there too. I'm going to talk a little bit about a grant that I wish Margie Snyder were here. She's the big PI, that John Schomer is the Minnesota PI, and I'm the PI at Wisconsin. So Purdue, though, is the real home of this. And this project is one in which we are taking a tool that had been an electronic tablet that had been used in LA with low-income clinics to identify patient-reported outcomes related to depression, quality of life. So we're taking an existing electronic tablet and we're basically changing it to try it out in community pharmacy settings to deal with to assess adherence kinds of issues in community pharmacies. So my idea today was to share with you just a small piece of this, which was the stakeholder advisory group process that we went through. And I wanted to ask myself this question and share it with you, which is, could we use a toolkit? This is what I asked myself during the time of our doing this project that I had developed with colleagues at University of Wisconsin for face-to-face stakeholder engagement. Could we use this in a virtual stakeholder engagement model? So that's basically what I'm going to talk about today. So using the same toolkit to assist virtual meetings. So I'll describe this virtual longitudinal mixed multi-state stakeholder advisory group that we did for this project and explore something about the process and the outcomes. And I want you to know, I already told Beth that I'm not gonna, I gave up my 5 minutes of questions for Marcia because oh no, I think your work is so important. So anyway, but I'm happy to talk to all of you at any time, and you know that, so anyway. So let me just go back here, yeah, okay. Our virtual mixed advisory group was drawn from 3 different states. We had patients, we had pharmacists, we had pharmacy techs. We were going to have to do this via basically WebEx. So instead of doing this face-to-face stuff, which is kind of tricky sometimes when you're doing a mixed group of providers and patients, because how do you get the patients to be not intimidated? How do you get the providers to basically not be competing and sharing or whatever? So that's kind of the challenge here. And our goal of the advisors, to the advisors, of course, who were in these groups, was to advise us on how to structure our questions, how to do a variety of things with the patients who are going to be in the community pharmacy, because nobody had done this. And they're going to be doing this across the whole time of the study. This is a multi-year study. And we've had 3 meetings so far. So that's what I'm going to talk about, what has happened so far. A big challenge is picking questions. Now that may seem obvious to everybody, but picking your questions to ask in stakeholder advisory committee meetings. I know everybody who's done this in the room, there are many of you who've done it, you agonize over it. But one of the things that is so important is figuring out what are the questions that this group can answer. Okay, your providers, your techs, your patients. So that's, of course, what we tried to focus on more than anything else. So a big one was how should we introduce the idea of this electronic tablet to patients and pharmacies? We weren't sure how to do that. We got their advice on that. They said, mention privacy, because you're going to be talking about things that are private. And if you can do it on a tablet without anybody overhearing you, that is going to be a plus. So, okay, that was a good tip. They said, mention health conditions. Don't just mention the medication, which again is something that I would not have thought of. I would have thought, okay, we'll just focus on the medications. But what the patient said is, no, mention that you're dealing with the health condition as well. In terms of picking the questions, the other thing that I want to just mention quickly is we were very careful not to pick a question that we felt we couldn't implement their recommendations or advice, either because it was going to be too late a question for us because we've already decided it, or too early a question, too many things are in the way of actually being able to implement. And then don't pick a question with any IRB implications for obvious reasons. Basically, you crash and burn.
What is IRB?
Oh, I'm sorry, Institutional Review Board. So that's you, I'm sure you have the same thing and you live in a total sphere of it. Do you not? At least I do. I don't know. Okay, so this HTTPS is what I just thought if anybody is interested in going to the toolkit, this is the toolkit that we developed for face-to-face and that we basically were using to structure our virtual. So we would always begin with our advisors, all three groups together in one electronic room. It was very easy to do electronically. We just have everybody come into the same electronic room. Our PI, Margie, would share the overview agenda, with a screen. And I want to say in subsequent, after the first meeting, a really important thing was we always said, how was the information used that was gathered at the last meeting? That to us was the key to having our advisors feel valued, because we valued them. So that was a really important piece of it. Always sharing what decisions we had made or showing screens that we changed as a result. Okay, what we would do after we had our initial introduction to the meeting together, all of us together in one room, it was very simple electronically to move people into separate rooms. So we would move our patients into one room, we had our staff in the other room. I was the primary facilitator for the patient piece, and we always had a note taker. Vanya, I think you were the primary note taker. You can share you can also ask Vanya about all of this, and John, he was hanging in there also. So
I did the role of Beth Martin.
he was the timekeeper. Okay, Betty, move it. Anyway, we had introductions, we had ground rules for respect. I would pose a patient question, we would put it on the screen in front of everybody so that they were really, the computer helped to keep the focus, I would say. We called on people for reactions. I would ask an open-ended question, and then I would really pay attention to who was sort of in the background, not responding. And then I would say, well, Don, what are your reactions to raise comments there? So I really tried hard to involve everybody. I think we did pretty well at that. After comments, we would always check that we understood. That's one of those things that it's not so easy to do correctly every time, but anyway, we tried it. After we were through, we would summarize within our patient room what were the key recommendations that were coming out, what were the key points or concerns that came out. Then we would go back into our main room together, and each of the groups, the providers and the patients, would report to each other. And it was always interesting. I think we were always surprised from the patient room. Quite often we had similar reactions to things, but also there were times when they had completely different questions that have been asked that were just interesting for us to hear. So anyway, that sharing together was really important, along with we always laid out the next steps. What's going to be happening next? How are we going to use your information so that everybody felt that this was not just a checkup? Because it really wasn't. It was, we wanted to use it. So what are some of the lessons learned? Well, actually, one of the lessons, probably obvious to everybody, is that if you're dealing with tech, you really do need some people in the background who can help the consumers who might have some challenges. So we always had a few people available to help with that, but most of the time they did pretty well. We did pretty well with getting everybody on. Informality. This again seems like an obvious thing, but I think especially in the midst of the technology, it was important to have some sense of at least a little bit of connection between the advisors, at least I felt. So I really always tried to have a little bit of conversation with everybody informally before we started the formal meeting, you know, catching up on things, whatever, so that people were just a little more comfortable maybe giving their perspectives. And then the last thing I want to mention on this is that I think selecting people, whether it's face-to-face, but I think particularly for the electronic version, it's really important to get people who are sort of generous in nature in terms of not just sharing their ideas, but generous in nature in terms of listening and responding to others and trying to think of the overall agenda of where you're heading. How we identified these people was through baseline interviews in our participating pharmacies. At the baseline, we actually interviewed a number of patients and physicians and techs. So it was that face-to-face initial conversations that we had with people that allowed us to put together that group. So some bottom lines, surprisingly, perhaps, it was a little surprising to me, although I believed in them. The principles for the face-to-face engagement actually transferred really well, I thought, to our 3-state virtual mixed group. And across the 3 states, I actually did feel that having the technology, having done a lot of the face-to-face, I did feel that the technology in some ways was easier in terms of moving people to a separate room, moving them back from a separate room, having very clear demarcation of what our goal, okay, well, that's what we were doing when we were together in the big room. This is what we're doing now in our own room. It actually worked pretty well. So I now have a sense we could be doing cross-country. We could be doing cross-country these things. We can do it with Norway. We can be having, you know, we could have some engagement groups, stakeholder engagement with women faculty across the board. I am supremely confident now about this. This opens up some possibilities. This was a study funded by AHRQ, as I mentioned. I want to thank all the Patient Talk team, Margie Snyder particularly, got John Schomer, Jeff Curran, and so many others. So I just like to, we have a terrific team, so I'll just stop there.
Is there one question for Betty?
I have one. No, go ahead. Well, I was gonna ask, how important is the personality or the personality of the facilitator? I watched you be very patient as some people were in a cabin way up north that didn't have good Wi-Fi, and you set the tone by remaining patient. Is that a prerequisite to have a patient, you know, what are the main roles of the facilitator? Or can anybody do this? I don't think anybody could do this. Or do you think anybody can?
I know you could. No, I think you really have to want to communicate. I think you really have to want to listen.
Listen.
I think that if I were to say one thing, I would say you'd want to really have to be curious and really respect and value the perceptions of other people, no matter what they say. That's my.
I agree, yeah.
The past few years have witnessed a rapid growth in the rates of drug overdose deaths, hospitalizations, and emergency room visits related to prescription stimulants. But it is actually not clear what role prescription stimulants have to play in this growth as opposed to illegal stimulants like cocaine or methamphetamine. The reason that is because current literature has not actually reached a consensus on the prevalence of non-medical use of prescription stimulants, and not for the lack of crime. If you look at current literature today, rates of prevalence of NMUPS range anywhere from 5% all the way to 35%. So let's look into why there is such a wide gap. Most studies estimating prevalence of NMUPS use a question that reads something like this. In the past year, have you used prescription stimulants in a way not directed by a physician? So let me set the stage here with a hypothetical example of an in-person interviewer asking a respondent this sensitive question. So what happens when you ask a sensitive question? It triggers privacy concerns, defensive responding, or what we often call social desirability bias. And we social pharmacy researchers often ask sensitive questions in all of our surveys. And what do? When we know there is social desirability bias? We add a line to our limitation section and move on. I am here to tell you guys there is a better way to do this. So let me introduce you to a technique introduced in 1965 by Stanley Warner and his colleagues called randomized response technique. In this methodology, the interviewer asks the respondent two questions at the same time, the sensitive question and a non-sensitive dummy question, both of which have a yes or no answer, right? And then the interviewer tells the respondent, I'm going to hand you a randomizing device, like a coin toss, right? And you toss the coin. If you get heads, you answer the first question. If it comes up tails, you answer the second question. And then the interviewer leaves the room. The respondent then flips the coin, notes what the outcome of the coin toss was, and then puts the coin away. When the interviewer comes back into the room, the respondent just gives an answer, yes or no. So now the interviewer does not know the outcome of the randomizing device and can never tell if the respondent answered the first question or the second question. So we have virtually guaranteed the respondent's privacy, and the interviewer can never know if any individual respondent was answering the first question or the second question. And while we cannot tell each individual's answer to that sensitive question, we can still estimate population level prevalence using a formula so simple you could do it on the back of an envelope. Right? All you need to know to do this formula is the probability of fails. You need to know how many people said yes to your randomized response technique question, and you need to know the probability of the non-sensitive dummy question. I'll get back to that in just a little bit. So there is a very simple formula to estimate this population level prevalence. I will say that the method I just walked you through was what Warner proposed in 1965 in an in-person setting. But since then, several researchers have extended it to paper and pencil surveys and online surveys as well. All right, let me walk you through our study today. We conducted an experimental study where our goal was to estimate the differences in prevalence obtained by the direct survey response method and an online adaptation to the randomized response technique or the crosswise randomized response technique. In our study, we sent out a survey to 1,200 college students at the University of Mississippi. Half of them were randomly assigned to DSR, the direct survey response, and half of them to the crosswise RRT technique. Individuals in the DSR group saw the non-sensitive question and the sensitive question on two separate screens of the online survey. Those in the CRRT group saw our CRRT question, which I will walk you through now. So in the CRRT question, we displayed to our respondents these two questions on the same online screen. The first question said, were you born in the first 10 days of your birth month? The second question said, in the past year, have you used prescription stimulants in a way not directed by a physician? The respondent was then told not to answer either question, but to tell us if their responses to the two questions were the same, both yes or both no, or if they were different, one yes, one no, or one no and the other yes. Once they told us those answers, we then chucked it into the simple formula I showed you earlier, and we found that the prevalence of non-medical use of prescription stimulants in the direct survey group was 18.2%, 18.6, excuse me. But in the CRRT group, it was nearly double at 32.5%. And of course, that was statistically significant. The p-value we obtained was 0.003. So a quick note here about RRT. This is not a novel methodology, but it has been used in the past for several other sensitive behavior estimations. RRT can improve respondent privacy, it adapts well to in-person settings, online surveys, and it can improve validity. But on the downside, RRT does make your analysis slightly more complicated. I say slightly because while there are some additional steps, the mathematics behind the analysis is actually really simple. And most statistical software packages today, some statistical software packages today offer you options to handle this sort of methodology. This increased analysis actually comes because that randomizing device adds random noise to your prevalence estimate. So in order to obtain a reliable estimate of prevalence, you actually have to use larger sample sizes than you typically would for a regular old study. But in return for using the larger sample size and for doing a slightly more complex analytic methodology, you get a more valid estimate for sensitive behaviors. So here's my implications for the study. We found that prevalence of non-medical use of prescription stimulants on college campuses may be much higher than previously estimated. The RRT methodology, though, has applications far beyond non-medical use of prescription stimulants alone. Like I said, as social pharmacy researchers, we often ask a lot of sensitive questions in our studies, whether that is about individual health status, whether that is about social determinants of health, whether that is about behaviors that they engage in, whether that is non-adherence or other things. I think there is a lot of potential for applications for this technique. And while I did not cover some of this methodology, simple things that we do in our usual studies, like conducting a logistic regression to predict who was engaging in that sensitive behavior, all of that can still be accommodated within the RRT methodology. And I didn't have the time to cover the stats behind there, but I promise you guys, it is not very complicated.
For you.
No, it really is not. It really is not complicated. I promise. I don't have a biostats PhD. But yeah, so I want to re-emphasize that when we ask sensitive questions in our surveys, it is important to carefully think about social desirability bias and to ask ourselves, what is the validity of these questions we ask in our surveys? And I challenge you all to find better approaches than to just add sentences to elimination sections when we deal with sensitive topics in healthcare research. Thank you, guys.
Very good.
Thank you for a very interesting talk. Can I just see if I understand? When you have to know the true answer of, or the percentage of people who say have burned in the first 10 days of the month, right?
So ideally, yes, you would have to know the answer to that question, but we did not. Now, we expected that about 30% would be born in the first 10 days of the month, but we weren't sure if that was the right number. So what we did was that the group that got the direct survey question, we asked them another question right after demographics and everything else and said, were you born in the first 10 days?
Okay, yeah, so you got it again, yeah.
But you did catch on to a really good point. The choice of the non-sensitive question is very important. It is important to choose a question that has a slightly high prevalence, but not quite close to 50%. And it is also important that the question you ask is not a question that respondents think you already know the answer to.
Yeah.
Because we were talking to college undergrad students, if they thought that the researchers knew their birth date, this methodology would not work. So there is a balance there.
Very interesting. So another method that I'm just saying this because it gives me the chance to refer to my favorite paper, which is something about, I'm going to try to find it and send out the link, but it's about zombies. And it's about asking sensitive questions. And the authors of this paper suggest that asking you if you are a zombie is quite a sensitive question. So they say that is not the way to do it. So they suggest that one way you could do it is asking, do you know any zombies? And then that way you get a more accurate estimation of number of zombies. But I was wondering, when you were reading literature around other ways of doing, did you come across that? Because I was wondering, what would people answer here if you ask, how many people do you know? Instead of asking, have you done it yourself, but how many people do you know who have used it? And what kind of numbers would that would be quite interesting to compare with it.
So that is a good question. Our study actually did include a question. We were trying to establish perceived norms of non-medical use of prescription stimulants on campus, but we found that the perceived norms question is biased by individual perceptions and their own social circles. So we end up finding that the perceived norms prevalence are close to 50, 60, 80% sometimes, right? And it doesn't quite get us the individual prevalence as well as something like RRT does. But not to steer this conversation to a completely different direction, but there is a whole other branch of trying to get at dishonest responding through what is called subtle scales. And I'm gonna talk about shuttle scales there because it's a huge different area, but it's asking questions that don't sound like they're getting at that sensitive behavior, but from respondents' responses, we can understand whether or not they were engaging in a behavior. So there are other ways to do dishonest responding estimation. That methodology, I think, is fairly common for some types of behaviors. For our study, I don't think it would have led us to a very accurate estimate.
Thank you.
Thank you. I would like to see that zombie behavior.
Yes, I have my.
Yeah, I would like to see that too. That's cool.
Oh, do you need to increase your sample size when you're doing this?
Yeah, absolutely. We had to do 600 people, which we would normally not have done 600 people for a study like.
Did you increase it from what you would normally do?
I would have normally done 200 to 300 perhaps.
Almost double?
Yeah, I would have said even if we had done 800, that would have been better than 600. Because while I was not able to present our AIM 2 results here, our AIM 2 results actually were underpowered because we only had 600 people, but 600 is a lot, right? For a general survey study, that's just the nature of RRT.
So that, just that term that he had up there also has a standard error associated with it. So it really makes your standard error bigger when you do that. That's why you need more people. There's more measure, there's more error.
I had a somewhat sort of related question. Did you mention how many items you had in the survey? I don't think I saw.
No, just to say the CRRT question is just a single question.
Just a single question?
Yeah, so this, this is the question.
So this is the one sensitive question.
This was the question. This is, I mean, we had demographics and we were measuring predictors of non-medical use, and we had other questions that were not related to this AIM I'm presenting today. So yes, there were other questions in the survey, but the CRRT part was just that is the question. You're seeing it right there.
So could you do that for as many sensitive questions that you want in the survey then? Would you
Absolutely. Now, if you do that for too many, I would be careful with the choice of the non-sensitive question, but 100% possible. Yeah, absolutely. And while these are dichotomous or binary questions, there is a way to extend your RRT method for continuous questions. So if you want to say, how many times in the past year did you engage in opioid misuse or something else like that, there are ways to accommodate such questions within RRT as well.
How did you learn about this?
Came across it in the literature, got one of those green little sage textbooks.
No way.
I'm not even kidding. There is a green sage book.
I'm certain there is.
On randomized response.
I remember
that helped me.
the shelf
Okay,
in
so full
our
disclosure,
graduate office.
I learned this in graduate school in 1987. It's all hot, you know? However, that leads to my question. Back then, it was you were in person.
Yeah.
And then you would grab a sealed container and you'd open it up and say, no, don't show me, just answer yes or no. And the one question would be like, are you alive? Yes or no. So you knew the answer. And then some of it was, do you use an illegal drug? Yes or no. And then after everybody was done and you knew exactly, you could figure it out.
Yeah.
So that is a randomly selected question. Is there anything online where it's a random question generator, or is that not viewed upon well by the review panels because you could maybe go look at history of the electronic footprint?
Yeah.
Do you see any random
That is a
question?
really interesting question. I know that some of the issues with earlier adaptations of the randomized response technique were to do with the fact that you could trace back electronically what the question was. But in the methodology that we use, in order to do this formula, you need to know the P. The P there is basically the probability of the non-sensitive question, the dummy question. But if you use too many dummy questions, now it's hard to know what each individual got. That would make it difficult to use that formula. So I'm imagining that that's a different adaptation of the RRT perhaps. It's not as favorable in the online world today.
I'd never seen this dual approach before. It's very
It's a simple technique to explain, understand, and implement, and I think it has some pretty powerful results as well. And I would say, if you're not interested, I'm doing a follow-up study where we are trying to do this with pharmacy students. So if you're interested in helping me pilot a survey among your students, please reach out.
International too.
Yeah.